Good morning or good afternoon, everyone. Not sure. Yeah, good afternoon already. My name is Елизавета Жолдасова, and I'm working at the Institute of Virology. And I'm excited to share with you our work on the formation of multidisciplinary systemic approach on viral microelimination of viral hepatitis in blood-borne risk groups, focusing on hemodialysis and hematology patients. How to move like this? Before moving to the concept of Uzbekistan program, I would like to begin with some global data. According to latest WHO report, HCV affects approximately 50 million people worldwide with a prevalence of 0.7%. And hepatitis B is even more widespread, with 3% of global population testing positive for HBs antigen. High-risk groups, such as hemodialysis and hematology patients, face significantly higher prevalence rates. Latest systematic analysis demonstrated pooled HCV prevalence 24% and HBV data for HBV ranging from 2 to 20%, and depending on the country. These patients particularly vulnerable due to frequent blood procedures, shared equipment, and immunosuppression. In Uzbekistan, the latest SERA survey results in 2022 showed that 2% of population are chronically infected with HCV and 4.1% of population HBs antigen positive. Unfortunately, we lack specific data on hepatitis prevalence among hemodialysis patients in Uzbekistan, which underscores the importance of the program. Further, I would like to share some information which I found on websites. This is success stories of examples of HCV microelimination in hemodialysis patients. First of all, it's Taiwan RAC and CHIPSI program, which achieved 96% cure rate with 97% patients treated and reducing new infection rate to just 0.1. And next is Argentina's national microelimination program screened more than 10,000 patients, achieving 92% sustained virological response rate. And they reported this success came from universal screening, a collaborative care model with gastroenterologists. These cases show how targeted strategies can eliminate HCV in high-risk groups, high-risk dialysis groups, and as it was reported by Dr. Esteban previously, in other vulnerable group, inject drug users. Uzbekistan's, I will move to our information. Uzbekistan's journey to combat viral hepatitis began in 2017 with decree of Cabinet of Ministry, which launched programs to prevent the spread of viral infections. Within the implementation of this decree roadmap, the background and infrastructure for further activities was developed through organization of regional hepatology centers, which served as starting point to decentralize diagnostics and treatment. From 2017 to 2022, two UHAP projects with help of CDA Foundation piloted large-scale decentralized screening for HBV and HCV in primary healthcare facilities, expanding treatment access. These efforts further laid the foundation for the comprehensive approach. In 2022, Presidential Decree 243 initiated a 4-year program offering free HBV and HCV testing, free antiviral therapy for HCV patients, and early liver cancer screening. In 2024, Building on the previous initiatives, Uzbekistan launched a pilot micromanagement program targeting approximately 5,000 hemodialysis patients and 4,300 hematology patients, group at high risk due to blood-borne transmission. Order number 211, issued on June 2024, prioritizes HCV elimination and HBV control and prevention in hemodialysis patients by 2025. The Ministry of Health within this program, the Ministry of Health, Sanitary and Epidemiological Service, Virology Research Institute, and Republican Nephrology and oncology centers collaborated to develop a detailed plan. While we lack baseline prevalence data for these groups in Uzbekistan, our screening efforts ongoing through 2025 aim to fill this gap. This pilot leverages a multidisciplinary approach involving nephrologist, hepatologist, and oncologist. The program is guided by is guided by a clear screening and treatment algorithm. Here, how it works. First, we identify hemodialysis and oncohematology patients and compile a registry of those testing positive for HCV and HBV. Then positive cases are referred to the Republican Nephrology Center of the Research or the Research Institute of Virology for confirmatory diagnostics with additional support from regional hepatology centers. After positive patients receive antiviral therapy monitored by a nephrologist following national clinical guidelines. All positive patients offered testing also for oncomarkers such as alpha-fetoprotein. They offered ultrasound diagnostics and, if indicated, MSCT to rule out primary liver cancer. All services are free for hemodialysis patients. Since 2025, the CDC division of viral hepatitis is supporting Uzbekistan, an initiative targeting approximately, as it was mentioned, 5,000 hemodialysis patients. Specialists from Republican Blood Transfusion Center and Republican Hematology Center was also involved in this on this stage of the program. First, with help of CDC experts, we developed the guidelines for infection control in extracorporeal departments, providing methodological framework for prevention, screening, and management of HBV and HCV. These guidelines was built on Uzbekistan's existing regulations and incorporate modern international standards such as those from WHO and CDC. Additionally, this project involved, as I already mentioned, Republican Center of Hematology, which specialists also contribute to the development of registry of patients positive for HCV and HBV in their facilities. After development of guidelines and instructions with help of CDC experts, we organized interdisciplinary training of trainers engaging approximately 100 regional nephrologists, blood transfusion specialists, and infectious disease specialists. From May 2025, cascade training sessions were rolled out across all regions of Uzbekistan. These sessions covered critical topics, including the latest infection control norms from Order 211, developed clinical guidelines for HBV and HCV screening and treatment, and hands-on instructions for using the newly developed hepatitis U's electronic registry. The training program includes demonstration materials such as videos and interactive modules to guide specialists in data entry and patient monitoring. While our work is ongoing now, and screening process and referral to treatment is at early stage but continues. We aim to establish a strong team and to boost professional and soft skills of the specialists involved in the training programs. But still, we have some challenges. We have some constraints in resources, especially in rural areas, and we need for sustained funding and coordination from the government to make this project sustainable. What we hope to achieve. Our pilot aims to significantly reduce HCV and HBV prevalence among hemodialysis and hematology patients, as it was done in Taiwan, for example. We expect to establish a replicable model for microelimination that can be expanded to other higher risk groups. In the short term, we'll focus on collecting baseline data, refining our algorithm, and scaling up the training programs. Long term, we aim to achieve zero viremia in targeted population and contribute to Uzbekistan's broader hepatitis elimination goals by 2030. In closing, our program represents a bold step toward microelimination of viral hepatitis in high-risk groups. And our work is just beginning, but with support of partners like CDC and the dedication of our healthcare teams, we're confident that we will succeed in our path. Thank you for your attention, and